So yesterday we started with beta-lactam antibiotics. We started with penicillin, and we have seen the basic things related to natural penicillin, how it was formed, what are the benefits it is offering, what are the problems it has got. Now let us see what are semi-synthetic. As I told you, why they call as semi-synthetic, because half portion is a natural, half portion is a synthetic. Therefore, we call them as a semi-synthetic penicillin. Why? How they are half natural? Because 6-aminopenicillinic acid, which is the basic structure, that is obtained from the cultures, that is from the fungal cultures, that is maybe Penicillium notatum or Penicillium chrysanthemum. From that, this 6 APA is obtained, and from this, in this 6 APA, the various groups are synthetically obtained. So this is chemical combination of specific side chain to the particularly into 6-aminopenicillinic acid. We call it as a combination of a chain. Just a minute. Hello. नाही आज 3दा आला मी तुम्हाला सांगूनच. So what we have seen is this is how we are going for semi-synthetic, where we are attaching something to 6-aminopenicillinic acid, that is 6 APA, and this structure we are binding. Now why we are doing this? Why we are going for semi-synthetic agents? What is the rationale behind this? We have seen some of the problems which were associated with penicillin G, or which we call it or benzyl penicillin or natural penicillin. What was that? First thing is it was acid labile, so it cannot be taken orally, because as soon as it is taken, the GIT will cause. It is enzyme labile, and so oral route is almost closed for that. Then second thing, that means it is always to be given by intramuscular or intravenous route. So this is one biggest problem. Second problem is there was a narrow spectrum of action. Okay, that is only gram-positive bacteria it was acting. It was not acting on any other bacteria or gram-negative because of specific problems we have seen it in mechanism of action. Then they are highly susceptible to penicillinase or beta-lactam is what we call. Because of that, they are going to get resistance very early. So if they are getting resistance, then they become useless. This is third important problem which we got. And fourth was it is hypersensitivity. Hypersensitivity can still be there with semi-synthetic also, but it was very bigger with the natural one. So these are the basic problems, and some of the problems we can have, we can answer, we can try to improve it if we make them as a semi-synthetic penicillin. So these are the benefits which are offered by semi-synthetic penicillin. We shall see what are these and how, what are, so for example is acid resistance penicillin, which is resistance to penicillin G. Then we call it as a pinoxymethyl penicillin. It is acid resistant, so it can be given by oral route. Example of this is a penicillin V. Then penicillinase resistance penicillin. Example of these are cloxacillin, methicillin. This was one of my favorite question, particularly which I can ask anytime. What will happen, suppose, because we shall see later, there are some agents which are used as a penicillinase inhibiting agents. Okay, if you remember Parkinsonism, if you have studied somewhere Parkinsonism, and in Parkinsonism you might have seen that there are certain agents which are used, isn't it, levodopa plus carbidopa. So carbidopa is not therapeutically effective, but it causes reduction in the levodopa metabolism. Similarly over here, there are certain agents which are penicillinase inhibitors. So they will not allow this penicillinase enzyme to act on the penicillin, and thus they will prevent the metabolism of penicillin. We shall be seeing them later. But if these are the penicillin resistant penicillin, then there is no need to add them. So if somebody says that I am adding cloxacillin plus sulbactam or clavulanic acid, which are the penicillinase inhibitor, then there is no meaning of it, that is useless. So these are example of these are cloxacillin, methicillin, these are penicillin resistance. Then extended spectrum penicillin, example of these are aminopenicillin like ampicillin, vacampicillin, amoxicillin, and out of that this ampicillin, amoxicillin are still very good in practice They are still widely used. They are having good effective, and they can be given orally. So they are acid resistant also. They are having extension of spectrum also, and they are effective also, and very less resistance is there. So these are still in practice, still they are widely used. Ampicillin, amoxicillin, like this. Then next is carboxypenicillins like carbenicillin, ticarcillin. Then iridopenicillins like mezclocillin, piperacillin. So these are various semisynthetic analogues, and these are various penicillin derivatives which are active. So first on this is penicillin V. It differs from penicillin G only in that it is acid stable. The absorption, oral absorption is better, but other things are almost same. That is, it is identical to penicillin G. Less active against Neisseria and other gram-negative bacteria and anaerobes. It is not dependable in the serious conditions. It is primarily for streptococcal infection like pharyngitis, sinusitis, etc. Doses 250 to 500 milligram. There 250 milligram is equal to 4 lakh units. So it can be given like that. Then penicillin has resistance penicillin. They have side chains that protect the beta-lactam ring from attack by Staphylococci penicillin. Their only indication is infection caused by penicillinase producing Staphylococci infection, for which they are drug of choice. Example of these are cloxacillin, which is highly penicillinase and acid resistance, can be given orally. Effective against penicillinase producing bacteria. Doses 250 to 500 milligram. Then other are similar to cloxacillin are oxacillin, dicloxacillin, flucloxacillin. They are similar. Flucloxacillin is not available in India, others are available. Then next is methicillin. This is highly penicillinase but not acid resistance, so it must be injected intravenously. MRSA has emerged in that is multi-resistant. These various strains are there, so it has been emerged in many areas. They are insensitive to penicillin as resistant penicillins. Other beta-lactam and erythromycin aminoglycosides tetracyclines, they have altered protein binding, penicillin binding proteins. They are different. They do not bind penicillin to this. Then they can be used with the combination with vancomycin, linezolid, ciprofloxacin, etc. But they can cause nephrotoxicity. This is the biggest problem. Extended spectrum penicillins, example of these are, we have seen this, they are amino substitution in the side chain. So ampicillin, amoxicillin, etc. So they are active against a variety of gram-negative bacteria. Some are active against Pseudomonas, Klebsiella, Proteus, which are lacking porine channels. They are active, example one by one we shall see, active against all organisms like penicillin, wherever penicillin G is active, they are also active. But one thing very important, as I already we have discussed it, penicillin G is the most active against these gram positive. So if we compare where there are susceptible species, then penicillin G is the most active dose to dose if we will compare. Okay, but ampicillin has advantage that it is also acting on many gram-negative bacteria which are like hydrophilic, and because of the hydrophilic structure, it can penetrate the porine channels, and therefore it is very active in these agents. It is active in influenza, E. coli, Proteus, Salmonella, Shigella, and most of the bacteria has developed resistance to it. The pharmacokinetics, it is orally absorbed, incomplete but adequate. Food interferes with the absorption, and therefore it has to be taken 1 hour before meals. The excretion is, this is not applicable for amoxicillin, it can be very well taken with the food. Then primary excretion is through kidneys. Dose is 0.5 to 2 gram orally or intramuscularly or intravenously, 6 hourly can be given. Adverse effects are diarrhea, unabsorbed drug irritates the lower intestine, and it causes alteration of normal bacteria flora. This we have considered, this alteration of normal bacteria flora during general consideration of antibacterial treatment. We call it as a superinfection. If those who were absent at that time, they can go through it, they can study what it was and how it is affecting. So, what are the importance of bacterial flora, how they are helpful, how they are beneficial to the human beings, and if it is affected, then what will be there, and how we can take care of it. Then other adverse effects are rashes. The other ampicillin is vancomycin. It is a prodrug of ampicillin, completely absorbed. It does not disturb the intestinal ecology. Incidence of diarrhea therefore are less. There is a higher plasma level are obtained. Better tissue penetration is there. Then other analogues are telampicillin, fuampicillin, etacillin. They all are prodrugs of ampicillin, and thus they improve the viability of ampicillin and reduce other problems. Then amoxicillin is a congener of ampicillin. It is similar in all except the oral absorption is better. The food does not interfere. Then higher and more sustainable blood levels are there. Incidence of diarrhea is less. It is less active against Shigella and H. influenza. So these are the advantages it is having. Then aminopenicillins, they are used in many places in almost all infections. In dentistry, it is used alone with other metronidazole in various ulcerative gingivitis, that is pus in the gums, or periodontitis, pulpitis, dentoalveolar abscesses, Ludwig's angina, osteomyelitis of mandible. These are all dental activities. Then various urinary tract infection, respiratory tract infection, meningitis, gonorrhea, typhoid, bacillary dysentery, cholecystitis, septicemia, and mixed infection in various infections. These are used. Then uridopenicillins are the another one. Example of this is a piperacillin. It is having further extension of activity, that it is acting against Pseudomonas, and it is 8 times more active than carbapenicillin for Pseudomonas. It is also having good activity against Klebsiella. Dose 3 to 4 grams 6 to 8 hours hourly. It is available in combination with the tazobactam. We shall see what tazobactam is. Then piperacillin is combination with beta-lactamase inhibitors. It has broadest antibacterial spectrum against penicillin. It has high biliary concentration which are achieved. Important agent for treatment patients with serious infection called by Pseudomonas, Proteus, and Klebsiella, which are having the symptom signs like bacteremias, pneumonias, infection following burns and UTIs, Pseudomonas infection in neutropenic and immunocompromised patients. So in that, this piperacillin is a drug of choice. It is one of the best agent. What are the adverse reactions? They causes pain and steroid inflammatory reaction wherever the injections are administered. Then phlebitis and thrombophlebitis on the intravenous injection. Phlebitis means inflammation of that vein or blood vessel, and thrombophlebitis means along with inflammation of that there is a thrombus formation nearby, so that is a problem. Nausea with or without vomiting, mild to severe diarrheas. Particularly diarrhea will be more where there is a superinfection or where more affecting the intestinal bacterial flora. Mental confusion, muscular twitchings, convulsions, coma they can cause. Procaine has more adverse effect like hallucination, convulsions, because procaine has got these activities. The biggest problem, we have seen that penicillins are very safe. Even 100 times dose we can give. Suppose it is 1 gram is dose mentioned, then you can give even 100 gram without problem. We call it that it has got very high therapeutic index. But the biggest problem, another problem is in some patients wherever there is a hypersensitivity to the penicillin. Why there is a hypersensitivity? We have seen it during immunology, that some of the drugs, they are acting like haptens. With that, some of the body proteins they bind, they become bigger protein molecule, and they behave like as a foreign protein, and because of that there can be hypersensitivity reactions or immunological reactions. It is incidence is comparatively high. It is 1 to 10%. It causes rash, itching, urticaria, fever, and the biggest problem is acute anaphylactic reactions. Now those who want to study, they can go for what do you mean by anaphylactic or anaphylactic reaction. You might have studied it in second year pharmacology in various adverse drug reactions. In that these anaphylactic reactions are IgG mediated and IgE mediated, and this IgE mediated anaphylactic, they are very severe. It causes release of histamine, or rather very big release of histamine, and can cause hypotension, can cause respiratory problem, and apart from that all skin rash, itching, etc. So it has to be checked. I remember nowadays penicillins are particularly available in oral format and they have little chances. But I remember when I was young, that time penicillin was only good medication, and particularly I had a few skin infections when I was just 4 or 5 years old. So that doctor will give me first small dose of on the skin, that is called as a sensitivity test. If I get any kind of rash, itching, or whosoever gets rash, itching, etc., then the doctor will not administer this antibiotic. Only other cases it will be administered. And in that cases, those who were expert doctors, they will be always administer adrenaline in their dispensary only. They will not particularly during visit, they will try and avoid, or always they will keep injection adrenaline and hydrocortisone handy, or antihistaminic agents handily, because adrenaline, we say that it is a physiological antagonist of histamine. So whenever histamine is released in very high amount, the counteractions, means it is not blocking histamine, but if histamine is causing vasodilation, it will cause vasoconstriction, like that. So because of this kind of totally opposite action, immediately the actions can be normalized, because patients may die with the severe hypotension in these people in these conditions. So these all immunosuppressant, hydrocortisone or antihistaminic, they were there. Then another severe hypersensitivity reaction, that is called as a Jeris-Alzheimer reaction. It's very common, particularly with penicillins, because penicillins were very good drugs for syphilis and spirochetes. So in that cases, when the spirochetes were killed, they will have their fragments, and these fragments will be very, very antigenic in nature. And whenever penicillin used, and because of that, these fragments will cause reaction. That particular reaction was called as a Jeris-Alzheimer reaction, and it was very, very dangerous one. Again, similar allergic response which was there to the drug. So these are the biggest problem the penicillin has. So when we say that penicillin was safe, penicillin was safest one, still these were the problems which penicillin was causing. Then we have seen that the biggest problem with them, with the penicillin, is formation of resistance. How the resistance is formed, we have seen one of the most important mechanism is synthesis of the enzyme like penicillinase or beta-lactamase. What will be the job of this? It will break down this beta-lactam ring, and therefore we call it as a penicillinase or beta-lactamase. Now what we can do for it? So we have got these are the enzymes which are produced by gram-negative or gram-positive organisms. They inactivate these beta-lactam antibiotics by opening the beta-lactam or cleaving the cleavage or breaking the ring. Now we have got various beta-lactamase inhibitors. Simply they will bind with these beta-lactamase enzymes. They will get metabolized before the antibiotic, that is penicillin derivatives, and thus this beta-lactamase will be made less useful, and these antibiotics will be useful. So what they will do? They are potent inhibitors of the beta-lactamases. They resemble beta-lactam antibiotic. They will be preferred over beta-lactam antibiotics, so they will get metabolized. They do not possess any antimicrobial actions. And if you remember, if you have seen, anybody has seen, I am giving the example of what? That is L-dopa and carbidopa. Similar case it is. The carbidopa is not therapeutically active. It prevents the metabolism of dopamine. Similarly, here they prevent the metabolism of beta-lactam antibiotics. They are binding irreversibly to the catalytic sites of beta-lactamase beta enzymes, particularly penicillinase, to prevent the hydrolysis of penicillin. So we can call them as a suicide inhibitors, because these are the enzymes which causes suicide in this penicillin. There are three types of beta-lactamase inhibitors are available. One is clavulanic acid, another is sulbactam, and a third one is a tazobactam. We have seen piperacillin is combined with tazobactam. We'll see others what they are there. Clavulanic acid is given by either oral route, parenteral route. It is derived from Streptomyces clavigerus. Sulbactam is a semisynthetic one, and tazobactam is a structural analog of sulbactam. These all can be given by intramuscular or intravenous use. These agents are given together with hydrolyzable penicillins to protect them from inactivations. They are extending the use of penicillin against beta-lactamase, which are beta-lactamase producing bacteria. How we are making combinations? Combinations are made on the basis of their pharmacokinetic features. Just now we have seen this in sulfonamides. In sulfonamide we have seen that why we are combining sulfomethoxazole with trimethoprim, because both are matching the pharmacokinetic behavior. Both are having similar half-life, almost matching half-life, not exactly similar, but then it becomes easy for the dose regimens. So here what are these example of these combinations which are matching, pharmacokinetic features are matching. Example is clavulanic acid and amoxicillin. Sulbactam is combined with ampicillin, and tazobactam is combined with piperacillin, and they are available in market as a fixed dose formulation. And this is one of the rational formulation. If you have studied rational drugs earlier, so this is one of the rational formulations, and they are it is rather advised that they should be always taken in this way only. They should be always taken in combination to avoid resistance and to avoid the overcoming resistance. So doses are like that: clavulanic acid 125 milligram, amoxicillin 250, sulbactam 0.5, ampicillin 1 gram, tazobactam 0.25, and piperacillin 2 gram. And all these are available as a fixed dose combination. They are most effective against beta-lactamase produced by staphylococci, then influenza, Neisseria gonorrhoeae, Salmonella, Shigella, E. coli, and Klebsiella pneumoniae. These are various microorganisms which are releasing this beta-lactamase or penicillinase enzyme, and thus prevent the action of penicillin. But if we add this various beta-lactamase inhibitors, then we can use penicillin in that without having any kind of resistance. So they are effective against beta-lactamase producing organism, and example, ampicillin combination with sulbactam is effective against beta-lactamase producing Staphylococcus aureus and Haemophilus influenza. Non-beta-lactamase producing microorganism, there is no advantage. Ineffective against methicillin resistant Staphylococcus aureus. So therapeutic uses, they are used in various conditions, various infection. Now simply thing is, wherever this ampicillin is useful, wherever the amoxicillin is useful, wherever this tazobactam is used, in all cases these are useful. Piperacillin is used, I am sorry. So these are the conditions where they are used. They are useful in various conditions. So here we complete various penicillins. I'll suggest you please go through this, read various things, check whatsoever additional data you find, and let me know if you have any difficulties in this.